Hi everyone, Vincenzo Berghella here again from AJOG FM, the Pink Journal. Welcome to all of you to another edition of AJOG MFM Live. I have two outstanding friends and colleagues here next to me. I'll ask them to introduce themselves. Lanice.
Hi, my name is Lanice Coleman. I'm a midwife and I am the Director of Midwifery Services here at Thomas Jefferson University in Philadelphia.
Hi, I'm Daniele Di Moscio. I'm Assistant Professor at Sapienza University of Rome, and I'm the Chair of the Social Media Committee at AJOG MFM.
And once again, Daniele, welcome back. Love your shirt and with the AJOG MFM logo, as everybody can see there. We have a wonderful program for you again today. I'm going to share what we have. Again, this is the three of us. And today's topic is evidence-based preparation before labor, a very important topic. We're very happy we could figure this out today. Lanice's post-call as usual, but as a midwife, can you share with us what an important day it is for us today?
Yes, it's International Day of the Midwife. So to all the midwives who are participating today, I celebrate you. And if you work with a midwife, know a midwife, have had a midwife catch your baby, please celebrate with them.
Really, really important. And I know, a lot of people watch us, including midwives. Feel free to participate. We'll tell you how in the next few slides. This is the seventh, I guess, in this series. We have gone over kind of what AJOG MFM is and what's going on in present and future. We had a wonderful session on manual rotation, on randomized controlled trials in obstetrics, on COVID vaccine acceptance. And yesterday was announced that over 1 million people have died in the US alone, in the United States alone from COVID. So please continue to be careful. Another small surge seems to be coming around, at least in our part of the world. COVID vaccine in pregnancy, ever more important. If you haven't watched that wonderful interactive sessions, please do. We did another one on ultrasound in labor. And the last one was on twins. And over 1,200 people watched it. I and many watched the other ones. Thank you for being so passionate about following us. You've been watching us on the AJOG MFM Twitter and YouTube account, and on my Facebook, Twitter, YouTube accounts. Daniele, as a social media guru, can you tell us some more about how to watch us and how to ask questions?
Yeah, so basically, as you told, to watch us, it's very easy. You should log in one of these social media accounts. You can go to Twitter and YouTube to AJOG MFM pages, or to Dr. Berghella's Facebook, Twitter, and YouTube account. But if you want to ask question, I think live stream is StreamYard, the platform we are using, is improving new functions. But right now, if you want to ask question, we tested last week with the twins live stream that asking question on YouTube is the easiest way to make some comments. So if you want to ask or make some comments, please go on AJOG MFM or Dr. Berghella's YouTube account and make all your comments.
Thank you. Thank you, Daniele. So we've been interested in labor and delivery for a long time. The evidence continues to evolve, and we have nothing to disclose except the passion for taking good care of a woman in labor and today before labor, to eventually get a good positive outcome, which every pregnant person wants. So we're going to start doing some live streams on some of the papers that we've published. And the first one is on before labor, but we have also published on induction, on first, second stage. And actually the third stage part was just accepted and will be after peer review and will be published probably later on this week or next week. And we have, as you can see, about half of them still to go. So thanks to the Pink Journal to having supported this major summaries. The whole series is based on the idea that prevention is better than cure. So while we care about postpartum hemorrhage or shoulder dystocia, etc., the idea is to prevent all those issues, infections, etc. And so these lectures are really on the healthy woman, the healthy pregnant person, and how we can prevent complications. And we want to provide you the level 1 evidence, which is really from systematic review and meta-analysis and randomized controlled trials. But we also want to make it applicable, to you. And these books, you can see them behind me, just came out. It's kind of a lifetime work with many of you who are listening of evidence, and also trying to put the evidence into, everyday life and our own experience. One of my things is that I think I'm for science and not for, a particular intervention. And we'll talk about quite a few today. And I'm also for change, as long as change makes sense. 150 years ago, we couldn't do cesarean deliveries. And we were doing episiotomies on most people. Even in my residence, I was doing episiotomy on everybody. That has changed dramatically. We've changed so many other things, and we need to be open to change and let science and common sense and good clinical care guide us. I'm going to actually put Lanice on, and because one of the things I talk about all the time is, did you brush your teeth this morning, Lanice?
I did.
And do you floss?
I do.
Very good. Very good. I won't ask you why, and I'm hoping Daniela does the same, but I'll show you why, you should do what you do. And I also did that. I can't leave the house without doing those things. So you guys should all brush your teeth, because there are actually 70 randomized controlled trials, and you can see the bottom of this. Every slide will be like this. Over 42,000 patients randomized. In this case, children, adolescents in particular. If you do fluoride, toothbrushing versus you don't, you actually prevent dental caries, tooth loss, et cetera, et cetera. And which I didn't know until I read, and now I do dental floss twice a day. In addition to toothbrushing, if you use dental floss, as you can see, home use of interdental cleaning devices, this is another large Cochrane, 35 randomized controlled trials, almost 4,000 people randomized, very recent Cochrane. You also prevent and control periodontal disease and dental caries. So that's, I call the previous slide evidence-based life. That's the way I try to live my life. I hope that's the way you try to lead your life. I would brush my teeth and probably, dental floss if my friends and colleagues like Lanice and Daniele told me, or my mom, or, my sister was a good, actually, mentor for me. But it's even, I think, more important to follow the science, and there is science. So on that, we'll bring to the science of evidence-based management before labor. Daniele, I when I asked you to participate into this, I hope I didn't cause you any stroke, and I thank you again for your help.
Thank you for involving me.
We covered a lot of ground, and this was a lot of work. It was a lot of work to go to the reviews, and here all the topics. So we'll cover them one by one. And again, this slide is to remind us that we're really talking about uncomplicated, in this case, vertex term, pregnancies. So Daniela, do you want to start summarizing, for example, some of the data, the best data, level 1 on perineal massage?
Sure. So this is the first issue we're going to face today, and antenatal perineal massage, I think, is it's one of the evidence-based preparation we should counsel more women during pregnancy, because there is lots of evidence that both before labor and during the second stage, antenatal perineal massage is effective, and if women perform antenatal perineal massage before labor, maybe with sweet almond oil, 5 to 10 minutes, starting from every day, starting from 34 weeks until delivery. There is evidence that antenatal perineal massage significantly increase the chance of having an intact perineum by decreasing perineal laceration and need of episiotomy. And if we use water-soluble lubricant during second stage, we face a significantly reduced chance of having third and fourth degree perineal lacerations. Lenise, can you explain us how to perform an effective antenatal perineal massage?
Well, I think it's important, sometimes people can get lost in the details and they get very focused on having to use a very specific type of oil, but sometimes people use olive oil or mineral oil. It's basically, and some people aren't comfortable touching their own vagina, and so they'll have a partner perform this massage. But basically liberally using an oil to thin out the perineal skin, kind of stretch the skin away from the vagina, and in a circular motion. Unless you're causing harm to yourself, there's no really right or wrong way. Again, people can get lost in details, but I think it's just using the lubricant and stretching.
And I think that's wonderful input, Lenise. These are I think a good example, and we'll have quite a few of things that don't really cost anything. I agree that you could use probably any oil. As you can see, there are 9 randomized controlled trials on this, probably by now maybe even more, and so there is pretty good evidence that the decreases and decreasing lacerations are so important. People can have major issues from, especially obviously 3rd and 4th degrees lacerations, and keeping that perineum intact as much as possible, or having only 1st degree, for example, instead of 3rd and 4th lacerations. I think it's extremely important. The next issue is something that I must admit, kind of came up as we were looking at this issue and looking at the literature, pelvic floor muscle training. Do you want to summarize, Danielle, again, what we found?
Yeah, so pelvic floor muscle training involving more than one daily sets of exercises with voluntary contraction of the pelvic floor muscles, starting about 8 weeks before delivery. So starting from 32 weeks. There is a pretty good evidence, even in this case, that pelvic floor muscle training in continent women, in women that are continent at the beginning of pregnancy, significantly decreases the onset of late pregnancy urinary incontinence, and mid postpartum we are talking about 3 to 6 months of urinary incontinence. Unfortunately, right now the evidence is weaker when we talk about women that are incontinent at the beginning of pregnancy, and evidence is also weaker when we talk about postpartum fecal incontinence. So the evidence coming from Cochrane is much focused on urinary incontinence.
And Vince, you and I talked about this. Neither of us really were aware of this, which is why it's so important to disseminate, our research. This is really something easy to do when we think about urinary incontinence, typically post-delivery, when it's already an issue. And, besides postpartum depression, probably one of the biggest concerns of the people that we see postpartum. So if we can get ahead of the curve and start this prenatally, we could significantly improve satisfaction in the postpartum period.
I mean, I guess these are what, I was trained to call Kegels, exercises. Do you have any particular way, Lenise, that you...
I don't. Like I said, I wasn't even aware that this could improve or decrease urinary incontinence postpartum. Sometimes teaching people how to do Kegels can be a little challenging, and sometimes a pelvic exam can help. But also, I talk to people about, if they're urinating and have to stop the flow of urine, those are the muscles we want to learn to focus on. And that kind of clicks in people's brains as a way to isolate those muscles.
We also have therapists, pelvic therapists at Jefferson, and I'm sure in many places that could help, doing some of this training. Again, like you say, I want to emphasize, this is a major issue. Some people don't even want to deliver vaginally because they're afraid they're going to be incontinent. And, or are afraid of pushing for a long time or whatever. And prevention better than cure. You can certainly have a vaginal delivery, and you just can do some prevention beforehand. The next issue is that we found evidence for in terms of preparation before labor. It's antenatal classes and education on self-diagnosis of active labor, Daniele.
Yes, so I think that antenatal classes and education of women on self-diagnosis of active labor are part of the are associated with the possibility of having a good childbirth experience, because women that are more trained and are educated in knowledge of themselves are, of course, more prepared during labor and delivery. So there are randomized control trials that show us that antenatal classes, and in these randomized control trials were 9 hours course of antenatal training before LND, before labor and delivery. It was associated with the possibility of arriving to the LND unit, so to the hospital, more often in active labor. And was also associated with less use of epidural analgesia and, of course, anxiety related to pregnancy and childbirth. As I told you, with a better childbirth experience. This was for antenatal classes, but also self-diagnosis, so education on self-diagnosis of active labor was significantly associated with the reduction, with the decrease of visits in the labor ward before the onset of delivery. So both antenatal classes and education on self-diagnosis are two effective methods, and there is lots of evidence also on these issues.
Anis, any pearls from you? Or I tell patients, it's great to go to perennial classes, but for us physicians, it's really important to go to what are called here again antenatal classes, or pregnancy education outside of your prenatal things. I'm sure you do that as a midwife yourself, but what's your take on some of this data?
Well, I think the more education, the more information we have, the more we recognize what's normal, when to be concerned. We learn how to trust our bodies. I think maybe as a midwife, I might see people who want less intervention. So maybe don't want to be induced or don't want an epidural and want to arrive in active labor. So having that education makes them a little more successful related to their goals. And certainly the more we know what to expect, the less anxiety there is. And again, more satisfaction.
Yeah. And, it's the same way I the more educated a patient I have, that's an excellent point. I think the easier the care I can provide, actually. This is something that when I first looked at, I was very surprised. But what's the evidence for X-ray pelvimetry, Daniele?
So X-ray pelvimetry is not useful because there is no reported benefit, and it increased the rate of cesarean delivery. So there is a Cochrane published on 2017 of about 1,000 women in 5 randomized controlled trials that tells us that X-ray pelvimetry should not be performed before delivery. There is no evidence regarding the use of MRI to perform pelvimetry before delivery. So neither X-ray nor MRI are suggested before delivery to study the maternal pelvis.
Anis, what are your thoughts?
I haven't actually seen any X-ray pelvimetry in my career, and I've been doing this for 20 years.
Yeah, these are old trials. I guess one thing we can expand on is, it's a tight pelvis, for bigger and bigger babies, we're delivering. Dystocia is certainly an issue. And, it made sense that many years ago, people looked at, let's estimate how big the baby is and let's estimate how big the pelvis is. Some people still do certainly, Leopold's, an assessment of not only the baby, but also the pelvis. I guess the point that they're making here, that the data shows, to me at least, is, if you do an X-ray and you think that the pelvic measurements are not great, you get scared, and while you try labor, you already have in the back of your mind she's never going to make it, and you kind of jinx the poor pregnant person to begin with. So sometimes actually, doing a test for which you don't know what intervention you have to change it, it's not like you can enlarge that pelvis, may be more harmful. And I think that's why there are more C-sections in those randomized studies. Do you assess the pelvis at all, Denise?
I do to a degree. I talk to our students and our OBGYN residents a lot about developing your hand skills. We should still be doing Leopold's. Often we want to run to our technology first and do an ultrasound to determine presentation. I said, that should be the last thing you just do just to confirm. We need to rely on our hands. There may be situations where you don't have access to technology. So developing hand skills is really important. I don't think I have the same skills as one of my former colleagues who retired a few years ago and taught classes on pelvimetry. But we should be able to recognize gross abnormalities and plan accordingly.
And, we are talking about, randomized studies and MRIs here and stuff. You, for example, work in health centers here in Philadelphia. And, we have a lot of patients who have no insurance, minimal insurance, very little health literacy. Maybe you can expand on that as well. And I think, sometimes, your point of Leopold's is well taken. Sometimes we actually don't have all the technology that may be published in the books and the journals.
Sure. I mean, I have a Doppler when I'm out working in community health centers, but I don't have access to an ultrasound. So if I need to confirm presentation with an ultrasound, I need to make an appointment for an ultrasound. And I think we're going to talk about this in the future about, using ultrasound to determine cervical length for labor prediction. Those are just resources that aren't available to most of the world. And so hand skills are really important. When we're even when we're in a large city in America.
The former chief of my school of specialization always told us that the young generation, we were born with the ultrasound probe in our hands, and we lost all our hand skills. He was a surgeon, an oncological surgeon, so he really cared about hand skills. But I think we should balance these two skills.
Absolutely.
So the next issue we found in terms of preparations before labor is weeping on membranes. Actually, can give you a little background, and I say this in one of the previous AJOG MFM live streams, that my first randomized study actually during residence was on swimming on membranes. So it's a small contribution, as you can see, at about many, 22 randomized studies out there. Daniele?
Yeah, so membrane stripping sweeping on membranes is a hot topic because many women are afraid of sweeping on membranes, because we have to acknowledge that it's an uncomfortable practice for sure. But we should balance that. On one hand, it's an uncomfortable practice. We cannot deny this. But on the other hand, there is strong evidence that membrane stripping starting from 37, 38 weeks until the end of pregnancy significantly reduce the duration of pregnancy and the frequency of a pregnancy continuing beyond 41 and 42 weeks. And when performed every 2 days until labor, it decreases the chance of induction of labor. So it increases the chance of spontaneous labor. Lannis, do you want to say something?
So I think this is really a chance where we need to get informed consent and do some anticipatory guidance. I always make sure people are aware that it is uncomfortable for the vast majority of people. And that also expect there to be some cramping afterwards and some late bleeding, and that it isn't necessarily going to make you go into labor, which I think is the expectation of a lot of people, but it can just decrease that time to the onset of labor. And then, it's very much up to individual preferences. Some people don't want any intervention at all and consider this to be an intervention. So just respecting personal wishes.
You remind me when I think when I started it again, 25 years ago, I think that maybe 10-15% of those women I stripped, after consent, went into labor, despite being 38 weeks and probably having a chance to go into labor anyway within the next 48 hours. And so it's really important people understand that, they shouldn't, pack their bags from the office once it happens. And again, the bleeding, uncomfortableness, it's certainly there. There's also some evidence that we can do it on group B strep positive patients. It's a lot of people have been scared and sometimes got into legal trouble because of that in the past. But the evidence, not from all randomized studies, but for some randomized studies that reported it, seems to say that even if you're group B strep positive, stripping of membranes is safe.
In Italy, many women call the practice, like not a practice, the practice. I went to the gynecologist and they did the practice. It's stripping of membranes.
Meaning it's routine. It's what do you mean?
No, but as many women are afraid or as are emotional linked to the sweeping of membranes, and so they consider the practice when they are a term. The practice is sweeping of membranes.
Interesting. And again, people are watching us from all over the world. We've had people speaking and listening from Australia, Canada, Africa, other places in Asia, Israel, Europe, certainly South America. So it's good to give a global perspective from other countries. This is something that Dr. Saccone, one of our friends and colleagues, put together a few years ago. I always felt really stupid walking into a room. That's why I put this little cartoon on the side of you walk into a room and I think a male looks more stupid than a woman. So that's why I put him there. And really, a lot of people coming in the office after 36, 37 weeks. That's what they want to know. When should I pack my bag, so to speak? When should I be ready? And we really have no idea. And this was interesting data, Daniele.
Yeah, so I think every woman would like to know when she's gonna deliver, and so in the past, many strategies have been studied to assess whether they could predict or not the onset of spontaneous labor. So the weather, no, it is not associated with changes in barometric pressure. So the changes of weather are not associated with prediction of spontaneous labor. Time of day, we should only say that there is a higher rate of women starting labor in evening and night hours. While if you want to talk about something that it is effective in predicting the onset of spontaneous labor, although the evidence comes from only prospective trials, so the evidence is not so strong. Transvaginal ultrasound cervical length examination is a good predictor to predict the onset of spontaneous labor. And we can say that the chance of delivering within 7 days increases as the cervical length at ultrasound examination decreases. So if you see a woman at term and the cervical length is 30 millimeters, the woman has less than 50% of chance of delivering within their baby within 7 days. While if it's 10 millimeter or less, there is a 85% chance of delivering within 7 days. So it's not a exact prediction, but it's a good prediction of within of a birth within 7 days. Sorry. And you are the master of cervical length, Prof.
Yeah, we were surprised when we saw this. Like Lenitz was talking about before, for example, this is certainly not routine and not easy to do. You need time, you need the probe, you need the ultrasound, you need the patient consent. But I think for good or bad, a lot more ultrasound will be done towards the end of the pregnancy. People trying to predict how the baby would do during labor. We had an ultrasound in labor session that kind of talked about some of the predictive values of Dopplers maybe and other things in terms of the fetus. So I wouldn't be surprised that that we may do something like this. And again, for us in Philadelphia, some people come, from an hour away or more. If the cervical length is 45 millimeters at 37 weeks, the chance to deliver within a week is like 5-7%. Is very low. They could probably stay at the shore and enjoy their time, And while if they're there and their cervix is 5 millimeters, they should probably, move in a little bit closer, especially if it's not their first baby. So, and again, another comment is that the evidence on whether, for example, it's still limited. A lot of people think about the moon, even that's been studied as well. Full moon, not full moon. We all think it's an absolute truth from our training in young days, but the couple of articles on that seem to say that it's not the full moon or a bad day or a rainy day or snow. Certainly, cortisol increases at night, and that makes you go, in labor more often. Denise, was that your experience last night? I don't know.
That was my experience last night. As a matter of fact, we were talking about why people need to be in labor at 4 o'clock in the morning. But nature is nature.
Yeah. One thing that this reminds me of is, the issue of, we like it or not, inductions are here to stay. We can argue on indication and stuff. But some people, for example, have argued that, we do a lot of inductions early in the morning or early in the afternoon. Some people say, why don't you start like at 8 p.m. or midnight, when it's maybe more natural for the body to start in anyway. And there are some preliminary studies on that, and it doesn't seem to make a difference. But that's an area of I think future research. The next issues are actually, we'll cover maybe a couple of slides together on births and birth centers versus hospitals. A very controversial issue, a lot of heated debates, but I think an important issue to cover anyway. There are some countries, as you guys know, that do quite a significant number of on births, several in the US, especially in the West. There are tens of thousands of on births, and actually during COVID, this the latest data seems that has increased probably everywhere, not only in the U.S. So, do you want to go over quickly the evidence, Daniele?
Yes. So I have to take a breath, because I think this is the hottest topic of among these slides. So on births, there is the first thing we have to say that the evidence coming from randomized controlled trials is weak, because there is only one randomized controlled trials in low risk women, and only 11 women took part of this study. But there are several retrospective studies on this issue. We can start saying that in 2028, the American College of Obstetricians and Gynecologists say that each woman keeps the right to make an informed decision about their place of delivery. And of course, we all agree with this. But women should be acknowledged that hospitals and accredited birth centers are the safest settings and place for birth. And this is because the evidence, although is weak, as I already said, and coming from retrospective series, show that home births are associated with an increased risk of perinatal and neonatal deaths, so perinatal and neonatal mortality and morbidity, and in particular neurological morbidity, with an increase of the rate of seizure and neurological complications. And also the women that many women, about 20 to 50% of women planning to deliver at home, then need to be transferred to the hospital. Of course, the hospital is the safest place for birth. And then, as Dr. Berghella said, we can argue that that maybe in those countries where the healthcare services are more open, are more organized to support home births, maybe the risks are reduced. But the evidence right now is that hospital and birth center alongside birth centers are the safest place, and home births should be considered only for low risk women, because of course women with some risk during pregnancy should of course deliver in hospital and alongside birth centers.
What about those alongside birth centers?
Yeah, alongside birth centers, that it's a place cared and led by a midwife in a location in the hospital. So and that is usually close to the regular labor and delivery wards. So it's in the hospital, like close to the L&D, so that if there is an emergency or something that is not going in the right way, the women can be fastly transferred to the regular L&D. This is an alongside birth center that is different from a freestanding birth center that is not close to the hospital, and there is no randomized controlled trials assessing the safeness of the safety of freestanding birth center. But there is a Cochrane that is evaluating alongside birth centers, and of course alongside birth centers, women that deliver in alongside birth center as requires less intrapartum analgesia. There is a reduced use of oxytocin, of episiotomy, and the rate of vaginal delivery is higher. Of course, it's higher the rate of breastfeeding at 6 to 8 weeks, and of course, maternal satisfaction, so childbirth experience is much better in birth centers. But we have to also acknowledge that there is also a non-significant, but there is a trend, 67% trend toward increased perinatal mortality. So all these positive effects, and in particular, I think it was a 4% increase of spontaneous vaginal delivery rate, should be balanced with this not significant trend towards increased perinatal mortality. This is, I don't want to say that alongside birth center are not safe place. These are safe place, but we have to acknowledge women should be counseled when planning where to deliver, should be counseled of all these data.
Denise, what are your thoughts on place of birth in general? Tell us maybe what you do, what you've done in the past. And
so I have always worked in a hospital-based birth setting. The people that I've cared for come from all over the world, and often have many health conditions that would risk them out of delivery at a birth center or certainly a home birth. I also care for people who have birth plans and their expectations and their desires for birth can't be met in a hospital setting. So those are people who, if they're low risk, I will suggest that they seek out a birth center. And in Philadelphia, we have one of the oldest freestanding birth centers in the country, with excellent outcomes. People have very strong emotional reactions to birth setting. But regardless of how we feel as providers working in a hospital-based setting, I think we have to have good relationships with community-based midwives, particularly midwives who are delivering in homes. We've seen an explosion of home birth, the desire for home births in our community since the onset of COVID. People are afraid to deliver in hospital, or they are fearful of the policies that we've set since COVID began, limiting who can be present in the hospital for a birth. So with that explosion, we still have a 20 to 50% transfer rate. And when I first moved into this community, there was a lot of hostility to community-based midwives. And so we saw a lot of people being dropped off at the front door of the hospital without records and without any really good insight into what had been happening during a labor course. And we've worked really hard to establish good relationships so that if someone needs to be transferred to a hospital, if there is a problem, that we get good information. Often that midwife will accompany a patient into the hospital So we have a good transfer of care, full information, and much more successful outcomes, and much more satisfaction in the long run. So regardless of how you feel about out-of-hospital birth, I think establishing good relationships with all the providers in your community leads to safer outcomes across the board.
Yeah, I completely agree with you. I always make a couple of examples. In Florence, in Firenze, in Italy, there is a kind of a hospital and a birth center next to each other. The birth center is a beautiful name. It's called La Margherita, the flower. And there's a corridor basically, connecting the two. So there are pools and water, jacuzzis, etc., and wonderful midwives, and a lot of patients deliver there. And again, we'll experience it if there's a drop cord, or forget an amniotic embolism, or eclampsia, whatever things that sometimes can be predicted, but sometimes cannot be predicted that much. Somebody can be just wheeled down, and there's C-section and ICU and blood transfusion and whatever else may be uncommonly needed. And again, the numbers are very small. We talk about percentages, but the chance that something goes wrong, for example, in a alongside birth center compared to a hospital, it's like 2 in 1,000 versus 1 in 1,000. It's less than 1%. So I think we look at the data, and which is not great to begin with. And you mentioned the one in Philadelphia. It's wonderful, established, great accredited midwives. They're across the street from the hospital. They have an established, wonderful, as far as I understand, relationship with the hospital, and I think the patients love it there. And some of my researcher friends say the maternal satisfaction should be the primary outcome of everything we do. You can argue that back and forth, but I think it's really important, and it's clearly better in birth center. And I'll go to the next topic. Especially when you're taken care of by a midwife, which actually doesn't happen as often as it should in these countries, but in many countries it's routine. Everybody in many countries in Europe, the physician doesn't take care of normal labor. So, Daniela, can you start reviewing this data?
Yes, as you told, it's not only about labor and delivery, but the whole pregnancy care that is led by a midwife. And there is a strong evidence coming from meta-analysis of randomized controlled trials, more than 15,000 of women randomized. And this Cochrane showed that a midwife-led pregnancy, so not only labor and delivery, but the whole pregnancy care led by a midwife, was significantly associated with the decrease of instrumental vaginal delivery, with a 24% decrease of preterm birth less than 37 weeks, with a 16% of reduction of perinatal death, with the less use of intrapartum analgesia, and a significantly higher rate of spontaneous vaginal delivery, about 5%. And of course, the pregnancy and the labor and delivery care performed by a midwife was associated with less intervention, like episiotomy, amniotomy, use of epidural and analgesia, and more maternal satisfaction that is translated in a much better childbirth experience. I think these data are very powerful, and yes, in our hospital there is a service that now has been improved with that is completely led by midwives, and women are happy about that, and we are more than happy about that.
So the International Day of Midwives, Lenise, we can stay on these slides as long as you want. Any comments?
I mean, I trained as a midwife. I had a partner the other day who didn't know what a midwife was. And, I was explaining our philosophy and where we came from, and the importance to me of teaching and giving resources and letting you make the decision that's best for you. I don't have to live with the long-term outcomes. You do. And he said, so basically what you're telling me is you care more and you're a great teacher. I said, I don't know if that's the case, but when we our practice came to Jefferson several years ago, we specifically wanted to have a collaborative practice where I provide primarily midwifery care, but as I mentioned before, some of the patients that we care for would risk out of midwifery care in many models. And so I get to share care with my OBGYN and MFM colleagues so that I can still bring my philosophy of shared decision-making and patient-centered care and trusting you as the leader of your healthcare team, but also have these great resources of OBGYNs and MFMs when someone has chronic health conditions that I can't manage, diabetes, chronic hypertension, preeclampsia with severe features, things that I need physician input. So I think we talk a little bit about collaborative care in one of the other slides and team-based care. Yeah, we also get the pleasure of, or the ease of taking care of a lower risk population sometimes.
Yeah, I mean, I think this is so important. What, I don't know as much about, but it's certainly been written about. It's, it's the caring and compassionate part you talked about. Some of this data, we're talking about kind of, the week before labor, in some of the slides, but this is really trust relationship, between two people, like you said, implied, Elenice. So, that starts early in pregnancy, or maybe even before pregnancy. She's trusting you, she's starting your small group, and then she comes in, she knows you, she knows your philosophy, everything has been discussed, and the patient does better. She feels less pain. But I'm amazed, when you look at preterm birth and perinatal death. I mean, very little things change, or more spontaneous vaginal delivery. Very little things change those outcomes. We study some interventions forever, and this is again a established routine in many parts of the world. I remember I was in Liverpool, in England, and the large women hospital there. Basically, that there is a part of a huge floor, and maybe it's more than one floor. It's just midwives, and patients are very happy being cared by them, and there's a bunch of doctors kind of in the corner somewhere else on that floor or floors that patients can be willed to if there is an issue or they need a C-section. But patients tend to be very, very happy, and this is a great evidence-based, really great care, and I think it also needs, to me, kind of people should play to their strengths. And I'm certainly much better at dosing magnesium for preeclampsia, and you're probably much better at caring on the minute by minute, hour by hour, sometimes longer and difficult labors.
Well, I think the point of this whole discussion is prior to labor care, and I think that's such an important part of having successful birth outcomes is the education up front, the team-based care that we have, having a nurse care coordinator who can make sure you have access to healthy foods, and our social worker making sure that, you can get insurance to help pay for your birth. So, all these and, care for your depression or anxiety, all the other important things that feed into successful outcomes. We measure birth outcomes, but there's so much that leads up to that successful birth outcome. And it's not just, midwife care, it's a team-based care, I think, that we don't often pay enough attention to.
So true. We could spend an hour just on that, but we'll move forward. We'll have it for another time. But that's really an important point. I'm glad it's going to stay there on the social media that Daniela leads for forever. So can you go over, and we'll go over the next two slides quickly, continuous support, and then we'll do training as well.
Yeah, so there is lots of evidence also on continuous support during labor and delivery, and continuous support is usually defined as an emotional support, and advice is given by a professional that is usually a doula or whoever a woman can choose to stand by during labor, and continuous support by that role, that professional, is associated with the higher rate of spontaneous vaginal delivery and with the reduced rates of cesarean delivery, instrumental delivery, intrapartum analgesia, lower 5 minutes Apgar's curve, And of course, like the midwife-led labor and delivery, the negative feelings about childbirth are decreased, and so the childbirth experience is much better. Maybe also because it shortened the the length of labor. And you can choose, the woman can choose whoever she wants. Usually she chooses a doula, but she can also choose her husband.
Oh, okay, sorry.
No, the cartoon explain why choosing an husband can be not a pretty good idea.
Yeah, he says, "Does it hurt? Can I get you a beer or something?" And why nobody uses mid husbands? It's an old cartoon. Lenise, do you want to comment on doulas in general?
Yeah, I mean, the use of doulas has exploded in recent years, for good reason. And I talk to people all the time about, your partner, your mom, your sister, your friend, cares about you very deeply, but they might not have a lot of experience with, discomfort relief measures or advocacy in labor. And they're very emotionally involved with you. And sometimes it's really hard to see someone you love in pain, and you want to provide relief for their pain. So, and they just haven't have a lot of knowledge necessarily. So a doula is someone who's really trained to sit down and talk about your birth preferences, your labor preferences, help you develop a realistic plan for yourself, and then advocate for you and remind you of what your plan is. Because sometimes things get really challenging, and people need that support, and someone who can say, let's try changing positions. Let's try to do this to stimulate things, labor to keep going. But also advocating, in a birth center, hospital based setting, when plans are changing from what an initial birth plan might have been.
And my one comment would be that the evidence supports that. Some of the details in this randomized trial supports the fact that yes, husband or a mother, some support, it's great, but if it's a professional, like you say, who is experienced, who you met before, she kind of knows your birth preferences, that's when you can really get a lot of those benefits that Daniele talked about. And I think it's important, again, that the woman knows. I think if she has a great midwives can almost act as a doula, but I think some of this evidence is for us physicians in the places where maybe that support is not offered as much by the professional, that a doula needs to be around.
In our setting, we think doulas are so important that, as we're limiting the number of people who can be in the hospital for a labor or birth, we don't count a doula as one of those people because we consider them to be such an integral part of the healthcare team.
Yeah. And quickly kind of finishing the provider's side, this is data from, we've talked about high income countries, but this is data instead from, low and some middle, but mostly low income countries. Limited data, but Daniele?
Yeah, limited data, but this randomized control trial show that there is a trend towards reduced maternal mortality and perinatal mortality when training the birth assistants compared with no training for birth assistants.
And the next issue that Lenise said, kind of talked about, it's teamwork training. What is the evidence for that, Daniele?
Well, the evidence on teamwork training, defined as courses on career resource management or communication, simulation, leadership. The evidence is a little bit conflicting because the first randomized control trials published in 2007 showed that there was no significant effect on adverse maternal and perinatal outcomes. But then other two subsequent randomized controlled trials were published, and they did show an improvement of team performance and medical technical skills, and an improvement of the use of evidence-based practice at birth. So the evidence is conflicting, but the latest evidence showed that maybe also teamwork training could be effective in improving skills in labor and delivery.
And Elise said it beautifully. I don't know if you want to expand on what you said before, but team always does better than the individual, in particular in this case, and now it's evidence-based.
Yeah, so here's my disclaimer. I'm a master trainer for a team-based training program. But I think we're seeing, since the onset of COVID and such rapid turnover in our staffing, how much team-based care is important in developing our communication skills and our situational awareness, all the things that are really important for safe outcomes. So I think it would be really interesting to do a study as we're, I'm working with so many new nurses and new staff members. Managing that and working in that team has become so much more important. So it would be interesting to do another study.
Yeah. And, I remember when the first study came out, Lenise, and I think it was even from Boston and Harvard in a major journal. And I think we were all very surprised. And I think it's an example of just don't stop, at the first study, don't stop at the first thing, maybe there's something, you didn't study enough patients, you didn't do it right, whatever. It's something that will make sense, works. And this is data mostly on obstetrics, but there is a lot more data outside of obstetrics, outside of medicine as well, on teamwork training and how important it is. I think in every field, this is important, but particularly in our field, life and death, this can make a huge difference. And I can only see more expansion and more research, coming out on teamwork training. A couple of other things we're going to cover. One is the late admission. Daniele?
Yeah, the late admission defined as a regular painful contraction and cervical dilatation more than 3 centimeters. There is old but randomized controlled trials of 200 women, and delayed admission compared with versus early admission significantly reduced time spent in labor and delivery unit. The use of intrapartum oxytocics reduced significantly the rate of analgesia and cesarean delivery. It was not significant, but it was a trend toward a 30% decrease of cesarean delivery. So delaying the admission of women in labor and delivery should be always performed.
And the last intervention I want to cover quickly are enema and perineal shaving. One thing I want to tell people, when I was a resident back in Manhattan in New York, there was a older, I think she was Cambodian nurse, L&D nurse, one of those medical figures you never forget all your life. She was kind of big and, in the middle of the night. And, we used to take 36-hour shifts. She made me laugh all the time. She would carry this huge bucket of soapy water with this, I remember, kind of grayish white large tube. And I felt like, anybody walk in, she will follow with the tube. And I was kind of trying to stay away from Guni, because she would give an enema basically to anybody who we admitted, to labor and delivery back then. And this was Manhattan, not a few decades, but not too many decades ago. So what's the evidence for enema and shaving?
Yeah, so these are two practices that were commonly performed in the past and now, but the evidence now is not performing routinely because enema is associated with no significant differences for infection rates and neonatal infection rates. And of course, it increased maternal discomfort. And also perineal shaving is associated with no differences for maternal febrile mobility or perineal wound infection or descents. And there are also potential complications such as redness or superficial scratches and burning and itches of the vulva and of course, maternal discomfort. So both these two practices should not be routinely performed before labor.
Any comments, Lenise, on
well, these two, along with routine episiotomy, are big fears of people. And I think if, when people are doing research for a birth plan, these are things that are frequently mentioned in the birth plan. So I think it's still out there in the media that these are fairly routine things that are happening. And in the 20 plus years I've been a midwife, this has never been a standard practice. So perhaps this is still happening routinely somewhere. But again, it's education. These are things we can easily say, we're not doing. You can take that off the birth plan. That's not an issue. But it is a big fear in the birthing community.
This last point you make, brings me back to one of the slides before, science and change. So, Lenise, when I was, again, back in Manhattan in a Lower East Side hospital there, so there were a couple of practices. There was the residence practice, and then there was a Soho practice. Soho, very nice private practice. I think they were paying lots of money for those deliveries. And we as residents used to make fun of that practice because that practice never did episiotomy, basically. People would push, and this was, the early 1990s. They would push, and of course there were some lacerations. We were so great, we were doing episiotomies on everyone. And that's what my chief would tell me, that's what my third year would tell me. And we had a lot of Chinese women with small perineum from Chinatown. And I really regret, so much of that. We had probably terrible outcomes. I don't even know the long-term outcome. So that's just one point to say that what we do today may be very wrong tomorrow. We need to study more, and we need to be open to change. Because you're doing something now you think is so great, doesn't mean that tomorrow we find out it may not be so great. And the important thing is to look at the data, because we didn't have much episiotomy data in the early 1990s, and then a lot of people studied it and showed that probably the less you do, the better people do. And but then you need to be open to change. Then you need to keep your eyes open and your ears open and listen to the science.
Vince, to go to the complete opposite end of the spectrum, we had a delivery last week and there was an episiotomy done. And I realized that none of the residents working that day had ever seen an episiotomy, which is not necessarily good either, because it can be a life-saving maneuver in some very specific circumstances. So we can't throw the baby out with the bathwater, but certainly limiting is important. But we had to debrief about it, it's interesting compared to your experience.
Yeah, no, very, very, very true. And again, sometimes, and we'll talk about this when we talk about second stage. But for example, if you're doing the rare indicated, forceps or operative delivery, and you need more space, or baby is not doing well, and episiotomy is the only way that baby can do well. That's an excellent point. I'll summarize quickly, since we're at the top of the hour, kind of what we went over. We amazingly, and we really didn't rehearse this, so I kudos to Daniele and Lenise. The perineal massage can be introduced kind of in the late third trimester to decrease lacerations. The pelvic floor muscle training can also be done to decrease the possibility of urinary incontinence after labor. The sweeping on membranes is associated with less inductions and less kind of going post dates. We talked about the very controversial issue of where to deliver, and that hospital, especially for high-risk women, better place, and alongside birth centers, certainly associated with some benefits and higher satisfaction when, again, near or in the hospital. Probably the strongest data we showed is the midwife-led care, even throughout pregnancy and certainly before labor, like we're talking about today, and in labor, associated with better outcomes and better satisfaction. And then the list is almost too long to go over. And the continuous support also, especially by a professional, is associated also with improved outcomes and more satisfaction. And in low and middle income countries, birth attendance, because labor is not so easy, can be life-saving. In this case, in places with high maternal mortality and perinatal mortality, can be life-saving for both the mother and the baby. And we say that many practices that used to be routine in the past should really not be practiced anymore. Weaker recommendations are, but as important, are about antenatal classes. We talked about prediction of spontaneous labor. We talked about the home birth. We talked about freestanding birth centers that need to be studied some more. We talked, and I put it in bold as the evidence is better, the importance of teamwork training and the better level 1 evidence we have now. And we also talk about the possibility of delaying admission till labor is a little bit more established, so that we, as providers and put physicians on top, don't do too much harm to somebody who's having a spontaneous, normal labor. So a lot we went over today. We will see you soon, the next week and week after that, and we'll talk about progesterone, very hot topic, and we'll talk also about induction of labor. Denise, do you have any final thoughts or things you want to share before we leave?
Oh, well, thanks for listening in. I think, as you just mentioned, what's standard now may be a thing of the past. Using evidence to support the care we provide is really important. And go wish a midwife a happy International Day of the Midwives.
Daniele?
Thank you for this wonderful hour spent together. Prevention is better than cure, and a happy International Day of Midwife.
Thank you both. Thank you everybody for listening. Bye-bye, everyone.
Bye.